So, item E, Madam Clerk.
Item E, discussion of the Coronavirus Aid, Relief, and Economic Security Act.
Chairman, thank you for switching the agenda a bit today. Dr. Minn is here, and in the interest of his time, we wanted to move this up. We have two components to the CARES discussion this morning. First, Dr. Minn will get up, and he'll kind of talk about three things and then answer any questions for the board. One issue he will talk about is antibody testing. He will talk about masks, and he will kind of talk about the numbers in Sedgwick County. Depending on the will of the board, antibody testing could turn into a request for CARES dollars, so that's why it's on this particular agenda item. And then after Dr. Minn is done, Lindsay will get up and give an update on the assessment, which is ongoing, as well as some other internal items from the county in relation to CARES. So we'll start with Dr. Minn. Thank you.
Okay. Thank you, Tom. Dr. Minn, I apologize for the delay in your being here, but
got things to do.
You got to see Sedgwick County government at work.
That's right. Gerald Minn, County Health Officer. I'd like to thank you for letting me come here today, although I will ask Mr. Stoltz, next time there's penguins coming, I wish you would give me some warning. I felt underdressed when they came in. If I'd known, I'd worn my tuxedo. But no one told me, so.
Thank you. That's Tom's fault. We will, noted, noted.
You need to enlighten me on the dress code. I thank you for letting me come here today. I want to acknowledge, before I start, that this has been a very stressful time since February until now. I know the public has been stressed out. I know we're all stressed out. None of us predicted this. None of us saw it coming, and it's had a major impact upon our society and all of us. I can speak for that personally as well as for everyone I know is feeling the effect of it. However, our goal is to keep this disease from overtaking our healthcare facilities to the point that we can't take care of the patients that need to come for other reasons. We want to keep the caseload as low as possible because even the people that don't need to go to the hospital would prefer not to get this illness and would prefer not to be off work for 2 weeks or have a serious illness that makes them feel very bad. And we'd like to keep the death rate as low as possible. Even though this disease affects the elderly disproportionately, we still have had young people that have serious illness, ICU admissions, and in some cases death, not necessarily in this county, but in this state. So that is our overall goal. Until we can figure out how to get a better way to control this virus, that's what we got to live with. So I was asked to speak a little bit more about this antibody test issue and what is the utility of antibody tests. In order to do so, I'm going to have to get a little bit into the science of antibodies and how they're useful and how in some cases they're not too useful. So any test we have in medicine, particularly antibody tests, have a certain degree of inaccuracy. We like to have an antibody test that is 100% correct, but there are very few out there that are 100% correct. So for instance, we like to see if we have a test for a disease of any kind, when we give it to 100 people that we know have the disease, does it always turn out positive? And if we give it to a group of people that don't have the disease, does it always turn out negative? Unfortunately, there are very few tests like that. So the antibody test has what we call a certain false positive rate. That means if you give it to 100 people that don't have the disease, it will come back positive on a certain percentage of those people. If the test is 99% good, but it's still 1% inaccurate, out of 100 people without that disease, 1 will come up positive, and we will call that a false positive. We have to teach our students at my medical school how they have to know those statistics on each test they do and how they need to know how to handle the possibility of a false positive. I won't go into why there's false positive. It gets in the complexity of the science, gets in the complexity of the biochemistry and the makeup of the body and the makeup of these antibodies. So I'm just going to use this board if that's okay. Is that permissible? All right. So bear with me. So say we have a test that's 99% accurate. I'll just use the word accurate. And for simplicity, I'm just going to say we have a group of people, 100 people that we're testing. We give the test to the 100 people, and of those patients, let's assume that none of them had the disease today. But because it's only 90%, 99% accurate, one patient's going to pop up with a positive test, and yet they don't have the disease. Okay? That makes sense? So, if we have a separate test, and it shows that most, in a different setting, that most of it's a mixture, 50% have the disease, 50% don't. Still, of the people who don't have it, one will probably pop up positive. The ones who have it, they will have positive tests too. Let's take these 100 people and say only one has the disease, fairly rare disease, most people don't have it. We give the test to the whole group. That one person will pop up positive because they actually have the disease. We'll still have, out of the 99 that don't have the disease, one pop up that doesn't have the disease. Equal numbers. We got two people that popped up positive. Which one's got it? We have to move on to other factors, which I'm not going to bore you with, to try and figure that out, which one's really got it. On the other hand, if we take 100 people and 50 of them, half of them, have the disease, much more common disease, pretty common out in the society. Those who get the test, 50 will come up positive because they have the disease, the rest of them won't. But still, of the 50 remaining who don't have disease, it's likely one will come up positive. Now this case is a little easier to handle because we can say, by far, the majority of this 51 people have got the disease. And so we can proceed as if most of them have disease, although this one will have to watch and do some more study. So my point is, the comparison between the false positives and the true positives, the ratio between those depends on how common the disease is, what we call the prevalence. You with me? And we have to teach our medical students how to handle this dilemma. And they have to realize if you have a very rare disease, you're going to have as many positives in people who don't have it as you have in the people who actually have the disease. I'll give you an example. We're not sure Lyme disease exists in Kansas. We're not sure the ticks here carry Lyme disease. The ticks in Connecticut, a lot of them carry it. So Lyme disease is very common in Connecticut. If I do the Lyme test in Connecticut and it comes up positive, I can be pretty sure that patient's got the disease. If I do a Lyme test here in Kansas, it's very unlikely. This is probably a false positive, and I better look at some other diseases because that's probably not Lyme disease, and I'm probably not going to treat them until we get that figured out. So the percent of false positives stays the same with the test because it's inherent in the test. But the number of true positives changes with how common the disease is. So the comparison between these numbers changes as the prevalence gets greater. So let's take it to COVID. As best I can calculate, we've had about We know we've had about 700 cases of COVID in Sedgwick County so far, 750, something like that. I'm just going to take that up to 1,000. We probably missed some. So I'm going to say 1,000 people in Sedgwick County have had COVID so far. And those 1,000 probably should have antibodies. But this is a county of 500,000 people. So you can subtract that number that have had it, 1,000 for 500,000, you still have 499,000 people that haven't had it. And yet of those 499,000, 1% is going to have a positive test. And they don't have it. So in that case, we think the prevalence of COVID in this country, in this county, is 0.1%. 1,000 people out of 500,000, that's 0.1%. Thank goodness it's fairly rare in our county so far. That's where we want to keep it. But of those, if we do the test then widely on this community, just everybody who wants to be tested, we're going to have about 5,000 people. I'm sorry, 500 positive, and yet we're going to have about 4,000. We're going to have a few fewer over here, 409 that are going to be falsely positive. So the true positives and the false positives are going to be equal. As long as the prevalence is as low as it is right now, the true positives are going to be about equal to the false positives. And so we got this dilemma. Who's really positive? Will the real COVID stand up, please? And that's going to require a lot of other testing, and we sure can't tell the people who are equal to the number who really have had the disease that you're safe to go back to work because you can't get the disease. That's not true. These are false positives. They're still not immune. Now, if we get up to the point where 20% of the population of Sedgwick County has had the disease in the past, okay? That means 100,000. Tom, I'm going to have to put some more marker in the budget here. That means 100,000 people will have a positive test. Over here, we'll have about, since we have a smaller group now that hasn't had the disease, it'll be about 5,000, 4,000 will be positive falsely when we do the test. Well, now we can get up to where if you're positive, we're pretty sure you've had it. So as the frequency of the disease, frequency of the infection rises, the accuracy of this test gets better, even though the overall accuracy as a percentage is still not where we want it. 99% is pretty good, though. There's very few tests in medicine that are that good. This is a problem we have to deal with when we have rare diseases, uncommon diseases. So my point is, hopefully we won't get up to the place where 20% of the Sedgwick County residents have had this disease. I hope we can keep it down here where this test is not going to tell us who's immune and who's not. Now, the second factor I have to mention, to this day, no one has proven that the presence of antibodies, even on the people who have actual antibodies, is protective. We don't have the science yet. Theoretically, you would think it would be, but we don't have the science yet. There are some disease where having in the past doesn't necessarily mean you're immune from it. Antibodies are not always the factor that determines whether you're immune or not. There are other mechanisms of our immune system that can fight disease that are more important in some diseases than the antibodies are. So my point is, one, because we're going to have, our disease frequency is so low in this county that we're going to have equal false positives to true positives with the test. And secondly, we don't know yet, the science is not there yet, whether having antibodies protects you or not with this disease. Unfortunately, we've only had this disease about 4 months, and the science is still evolving. We We've been scrambling just to take care of the patients. We haven't had the resources and the time to do as much research as we'd like. We hope we have more, we understand this virus better in a year or so, but the science just isn't there yet. The other problem we have is there are so many companies making the antibody test, and some of them are worthless. The FDA just let the companies release them and said we'll figure out whether they're accurate or not later. Now the FDA is pulling them back in and say, you got to prove your test accurate before we let you put it on the market, but you're already on the market. So even there we have a problem with which company's antibody test we're going to choose. Some of them are not 99% accurate. Some of them are much less than that, and that's going to compound this problem. We'll even have more false positives. So today I would have to tell you, I'd have to do some research to figure out which test you're going to do if you're going to do it, because some of the companies making it, it's not worth using. It's so inaccurate. I'm sorry if I bored you.
No, not at all.
But I don't like it. I wish we had a better test. I wish we had more knowledge about this. But I don't wish the frequency of this disease in this county was so high that we could rely upon the test. We don't want to get there. Now, the state has announced they're going to start doing some antibody screening in this state. They're merely doing that to figure out what the prevalence of the disease is, how many people. If they do the test and they only end up with 5,000 positive cases, they're going to say, that's how many false positives we would expect. So the disease must be rarely low prevalence. If, on the other hand, they end up with 100,000 people are positive, that far outweighs the false positives. So that means a fifth of our population probably has been infected. But they're doing it merely to determine prevalence, how frequent this is. And I've talked to the state health officer. He says, I'm not advocating this at all to help to determine who's immune and therefore is safe going around this virus. It is not there yet. The science is not there. The reliability of this test is not there yet. That's not why we're doing it. We just want to determine how many people in the state have been infected. Questions?
Okay. Thank you for the presentation. That's helpful and probably worth the public to understand this if they want to watch. So felt like I was back in college again a little bit.
Well, it's a little difficult to explain.
Understand. So Commissioner Dennis has a question.
Thank you, Mr. Chairman. A couple questions. I read in the newspaper just a couple days ago that the test that we're giving to tell whether you've got COVID or not isn't totally accurate either. So we're relying on that, but it's still going to give us false positives and false negatives and so forth. So it appears that no test is 100% accurate. But the concern I've had all along is that the test we're giving now, that nasal swab test, is only, and the paper said it's not 100% accurate, is only applicable on the instant that that person took that test. Mm-hmm. The next day or the next hour, mm-hmm. They may contract the virus. Mm-hmm. And you used the word prevalence. That's what I've been saying all along, is that we want to know what the prevalence of this disease is in our community. And since the test that we're giving right now is a snapshot, it's not going to tell us the prevalence because we don't know what's going to happen next hour or next day. And so I've been trying to find some method that we can get, instead of a snapshot, a motion picture, and that's the analogy I've used over and over again. And the motion picture is the prevalence. How widespread is this in the community? And it appears that the state of Kansas is interested in this too, or they wouldn't be advocating that we start doing some antibody testing so that we can find this prevalence in the community. So if it's important, and I think it is, why would you recommend we don't spend money to do the test for the antibodies, at least to start finding out what the prevalence is in our community?
So the tests are used for two different indications. The antibody test will tell us how many people have had it. Most of them will have recovered. They had it sometime, but they're recovered. The antigen test you're talking about, the PCR, is telling us who is infected today and transmitting the virus to others. The antibody test doesn't tell you that. Once they have the antibody, the virus is probably gone.
Well, I agree with you.
So-
The virus has gone out of that individual,
Right.
but we don't know that.
The test for the PCR, which is what we're using it for a different issue. We don't feel we have false positives with that test. It may not be 100% sensitive. That's another side of the coin. Now, I'm not going to get into sensitivity today. There are cases that are early in their disease and the test may come back negative the first time we do it. If we do it a couple days later, it's positive. But once it's positive, that means the patient has the disease. It's not a false positive. And those patients need to be isolated. They need to be taken out of the public so they're not transmitting to others, and they need to be watched closely for deterioration. This is asking a different question. How common is the disease in the population? Right now, we know in Sedgwick County, at most, we've had 1,000 cases. And so the prevalence in this county is so low, the antibody test, even if it was good, and we don't know for sure which vendor has got a good test yet, the false positives are going to be equal, and we won't know which individual patient. And that tells us the prevalence of active disease at this moment. It's not telling us how many people in society have had the disease. Because once you recover, this test, the PCR we use, is negative. It's only positive for a couple weeks. So I'm sorry this is getting into medicine and diagnostic tests, what question you're trying to answer. You could do a point prevalence and use the PCR to determine how many people at any one time are infected with the virus. This is telling us how many have been infected since January.
But I think that that's an answer that we need. The state of Kansas is looking for that answer.
So when the health,
Why wouldn't we be looking for that answer at the county level?
I believe the state is going to record which counties they're doing it in. I was told by the state health officer that if it was him, he would wait and let the state take on this project and for them to pay for it. And they can then and see what the state finds. If the state finds there's hardly any cases in the entire state compared to how big the state is, 2.8 million, there really isn't much use to dissect down to individual counties.
But you're saying we just need to wait for the state to decide whether or not they want to test anybody in Sedgwick County. But we have the ability to do it ourselves. Why wouldn't we do that? That's my question.
I think the state would not neglect testing in Sedgwick County.
But we can order those today. We can vote and say we want to do that. And now instead we're waiting for the state of Kansas to make up their mind, and who knows when it's going to happen. Why wouldn't we want to know what the prevalence is in Sedgwick County? That's my question over and over.
I have the announcement from the state here. Released a statewide strategy, used the 4 types of testing facilities. The implication, this was on June 12th, the implication was they were going to get started right away. If you want to get into the debate about waiting on the state or what, I think you should contact the state health officer and find out what their timeline is, and you'll have to decide.
But you're our health officer. Why wouldn't you make a recommendation that we want to know what the prevalence is in Sedgwick County? That's what baffles me.
I've tried to explain it. I'm sorry I haven't been effective in explaining it.
Thank you, Mr. Chairman.
Commissioner Howell?
Thank you, Mr. Chairman. Just a couple questions here. Is KU doing an antibody test, a study on antibodies related to COVID-19? Are they involved in doing some type of a antibody study at KU?
They're doing studies on the use of antibody infusions into the patients who are seriously ill. In other words, they're taking serum from people who recovered, they assume it's got antibodies in it, and they're giving it to some of the very sick patients to see if the antibody does anything. So they're in the midst of doing those studies now. The results are not known yet.
So they're not doing antibody testing on the community in any.
Not that I'm aware of.
Okay, all right. Appreciate that. I just want to, first of all, I would like to say appreciate you being here today. I would love an opportunity to sit down and actually chat over a cup of coffee. I think that's we deserve a little time with you to have maybe a deeper understanding of some of these issues. And I don't want to bore my colleagues or the public with my endless questions here, but I just want to ask you a couple little ones, I guess. We talk about a vaccination that may be available maybe later this year. I think that's, again, would be awesome if it was available. We don't know for sure if it's coming, or what date, when it will come. But if you could please describe, if you will, if someone was to get a vaccination, my understanding of vaccinations is they're injecting, if you will, something that looks like the COVID-19 virus. It's not a live cell. It's essentially a copycat of what would look like COVID-19 to the body. And the body's response to that is it creates the antibodies. Is that a fair way to describe that?
It creates an immune response, one component of which is antibodies, but there are other immune effectors that the body produces besides antibodies. Like I said before, your immune system has many modalities to kill invading organisms, one of which is antibody, but also has other mediators besides antibody.
Yeah, thank you for the answer. If someone was to actually have contracted COVID-19 or been exposed to it, and the body response would be to create the same response, whether it was done through a vaccination or through exposure, is that fair?
Yep.
If someone was to receive a vaccination, would you say to that person that they're immune from COVID-19?
That is part of the development of the vaccine. Once they get it developed, they're now in the safety trials to make sure the vaccine that's being developed doesn't harm the patient. Once they have felt comfortable, they've proven that, then they have to find out, does it really create immunity? It's not a given. They've had vaccines in the past that did not create immunity, did not protect you from disease, and that means they have to start all over. And that's why vaccines take years to develop normally. But they're fast-tracking this virus. They're fast-tracking this vaccine development.
I guess my question really is, assuming we develop a really great vaccination, and it is very effective on COVID-19, I don't know we would actually use the word that someone would be immune. That may be too strong of a word. I think even other vaccinations we receive today, I'm not going to get into vaccination debates today, but other vaccinations, sometimes people still contract the disease even though they have been vaccinated. That does happen, right?
And that's my point. They have to prove what its efficacy is. As you know, the influenza vaccine has not been near as effective as we would like, even though it does reduce the disease burden. On the other hand, some vaccines like tetanus, polio, measles, very effective.
Very effective.
You don't get the disease if you've had those vaccinations.
Very good. I do appreciate the illustration on the paper this morning. I do understand the point you're making, and I think that if we were to test a large number of people in our community and we had, let's say, 1% that tests positive for antibodies, it really doesn't tell us much. And I understand that. But if we had, something much higher than that, do you think that would be valuable to know that? If the numbers came back and they say we had 10 or 15, 20% of the people tested positive for antibodies, would that be valuable for us to know that?
If we can prove in the future with this vaccine development those antibodies actually kill the virus and prevent you from getting it, that would be valuable to know.
Okay. Well, I do think there's value in the antibody test. I would continue to advocate for it for other reasons. I think that if someone, I understand it's good to know what the community spread is. I think that's very important. I think that's why the state's interested in doing that testing. On an individual level, I don't want to give someone a false sense of security. Right. I think that's the concern.
Right.
But if someone did have a test, knowing that there's a risk of false positives or even false negatives, not to put too much weight into the results, but more than likely, again, if it's 99% accurate, 99% of that, if they said you tested positive, you have antibodies in your system, not to say you're immune, and not to say that there's not a possibility that's a false positive, but at least they would have some, I guess, comfort, if you will, knowing that they are most likely less likely to contract the disease. And I just think that's assuring to many people.
It would be up to the individual then to determine what they think, what their risk and security is. I would tell you, though, today, any of our physicians who are in the ICU at either their hospital taking care of these COVID patients, if you tested them for antibodies positive, none of them will go in that room without their mask and their security suits on. They do not have the confidence this test is going to protect them from those patients. They're not going to take the risk of getting the disease from those patients. Today, now in the future, maybe we'll know that the antibodies are effective, and maybe in that case they wouldn't feel the need to be so protected from those patients.
Dr. Mins, thank you for your answers, and I hope I can buy you a cup of coffee.
Sure.
We can spend a little more time
Sure.
with this. I've got
Happy
other
to.
questions, but not today. Thank you
Okay,
so much.
that's fine. May I go on, or is there more questions?
Commissioner Cruz has a question.
I am curious to hear what else you have to say, but I guess my main concern is we don't know if the antibody protects you. We don't know a reputable company to buy the test from. I mean, we scrutinize tractor companies more than we're scrutinizing this company. So, I mean, for me, it's all about if we're going to be spending money on tests that, from my understanding, are pretty expensive, not knowing the total need of our community yet for this COVID money, for the CARES money, I think we have to be prudent in how we spend this money, and spending money on a test that we're not sure works creates this false sense of security. We don't know what company it's coming from and how reputable the test is. Those are my concerns, and but I'm curious to hear kind of what else you were going to mention.
I wasn't going to say any more about the antibody test.
Okay,
Okay,
go ahead.
good. Please proceed, Doctor.
Just want to say a little bit about the numbers. I don't know if all of you have access to the report that we have prepared recently on the numbers. Do you have this? Health Department prepares this on the weekly numbers. It's on our website.
I think we received that yesterday, but I don't have a copy of it. Could we get a copy of that, Kate or somebody, please?
Looks like some of you have it.
We'll get you hard copies.
This shows by week what our numbers have been doing, and it's got on the left-hand column, it's got a number of the criteria we've been looking at. I will say we're fortunate. Yesterday, our numbers showed we had 17 people in the hospitals here. Not all of them were on the ventilator, and not all of them were in the ICU, but that's about the number we have. Do you need this? So, and I've talked to the hospital chief medical officers, and right now they got things under control. We're not overwhelmed. We haven't seen a significant increase in hospital cases lately, so we're feeling good about that. However, if you look at the other parameters, including just the number of cases we're seeing, we've seen an increase in the cases that we're seeing over the last week. We have corrected that for the number of screenings that we're doing, and it's up regardless of the number of screenings we're doing. We have deleted the clusters from that number and just looked at the things that appear to be community cases, not cluster cases, and those numbers are going up. So we have seen an increase in this last week. 3 previous weeks have been pretty flat, and now we're seeing an inflection going up. It's not doubled, but it's going up. That is of concern. I was concerned first week of June that with the Memorial Day activities and the demonstrations we were having in the streets, and the fact that we did allow some different venues to open up in the city, that we might see more cases. I don't know if any of those factors led to this increase last week, but it has gone up last week. So I'm just saying I think it's a time we need to stay cautious. I'm not advocating going back on closing businesses or anything like that, but the numbers are up. It's not due to clusters. It's not due to it's not all due to clusters. It's not all due to increased testing. So I just wanted to mention that to you, and if you wish to look this over a little bit more detail, I think it explains those things. Lastly, I know there's been some questions about some of the recommendations that have been made by the CDC and how effective they are. I know in particular there's been a lot of community disagreement and uncertainty about the effectiveness of the mask. I regret that the CDC originally came out in February and said that masks didn't seem to be so important, but after further research they kind of changed their minds, and now they're saying they think masks do have a lot of utility. So let me put it this way. We don't think we're going to have a vaccine any sooner than January 1st of 2021. That's optimistic. It may be longer than that. We don't have any drugs right now that decrease the disease, certainly no oral drugs. So it looks like for the next 7 months, even in an optimistic situation, we have limited tools in our toolbox to keep this disease at bay. So what do we have? Well, we could try to keep people importing it in from other countries and other states, travel restrictions, but those are hard to enforce.
Right.
Very difficult. We will be continuing, the health department is going to continue to do screenings, drive-throughs, and identifying who's positive at that moment, and then finding out who their contacts have been, and test their contacts, and then ask those people to remain isolated for at least 2 weeks so that they're not transmitting it to the public, trying to decrease the transmission rate by identifying the active cases as quickly as we can. That's the second tool we have in our toolbox. That's pretty effective if you can carry that, and I think we're doing a good job.
Yeah.
And I want to, at this point, commend our health department personnel. I think you have one of the best health department personnel for this disease of any county in the state. I can't say that for sure because I haven't worked with Johnson County and Wyandotte County closely, but they are working 7 days a week. 7 days a week they are active. They're looking at the cases, they're posting it, preparing reports. And I am very impressed with their technical expertise. So I think we need to be very grateful that we have a health department that's at the right time was available to handle this condition. The last thing we have to do to keep this disease at bay is our behavioral characteristics of our community. Trying to help our community to keep transmitting it from the people who have it to the people that don't. I know this is a pain. People don't like it. It's inconvenient. It's disruptive. But we don't have much else. So we need to keep reminding the companies that it's good that they're having 6-foot increments on their checkout lanes. It's great that they're having plexiglass to protect their cashiers. We need to continue that. For those who don't need to get out, particularly the elderly who are at very risk of disease, it's probably wise to stay at home as much as you can. That doesn't mean you have to be jailed in your home, but as much as you can. And then lastly is these things. I don't like them particularly. Doesn't bother me that much. But I do have a couple articles here that I'd be happy to share with you that do show some early scientific information that the masks do decrease the rate of spread. I don't know if somebody wants to take that. And that even the cloth masks have some utility. So why is this? We think when people cough or speak, they're emitting little micro droplets of saliva or nasopharyngeal material in which the virus is in. And if those little droplets land on somebody else or their hands touch somebody who has it on their hands from itching their nose, they can transmit to that person, and when they scratch their nose, they've now inoculated themselves. When people cough or speak, they're emitting little bitty microparticles. You can't see them unless someone really says a lot of P's in a row. So if you're doing the Pied Piper poem to your kids, you're probably emitting them a little bit more commonly than other speech. Or if you're shouting, you're emitting more of those little microparticles. We think the masks do attenuate, not necessarily stop. The viruses are not just floating in the air as a single virus. They're in these micro droplets. And we think these masks are fairly good, not 100%, at stopping those micro droplets. Now, so you may have seen a commercial on TV lately of a retail entity in town who doesn't just put a price tag on things, they make offers to people. And they show the guy getting ready to make an offer to someone about a purchase. And as they walk up to the desk to give the offer to the patron, they're handing out headphones to the other customers. And then they sit down and they give the offer, and the customer screams, "I can't believe this!" And they show the wind blowing papers everywhere and things flying in people's face. Now that patient should have had a mask on. she's inoculating a lot of people. So I'm not here to tell you the mask is great. I'm not telling you it's the best thing, but what do we have? What do we have in our toolbox? And if this mask keeps a neighbor from getting it, it's mainly there to protect you from giving it if you have the virus unknowingly. It's not so much to protect you from breathing in the virus. It's to stop your droplets from depositing out there and getting on someone's hands or getting in their face if you're up close to them. That's why we have the 6-foot rule. If that keeps a couple patients from getting admitted to the ICU, I'm willing to pay that price personally. I'm willing to do that because I don't have a lot of other tools to offer society, which I regret. So these articles, if you wish, you can read them. They claim that there is some element of science that suggests they are somewhat beneficial in reducing the transmission of this virus. They're not perfect. They're not as good as the mask that the doctors wear. So mainly I just want to say we're all trying to do the same thing. We're trying to get through this without causing more mental health issues. We're trying to get through this without causing any more economic damage. But we do need to do what we can to keep this virus from increasing. And the last week we have seen the cases going up. We want to stop that. We don't want it to go up higher. And I've given you the 3 tools we have to do that. And they're not as potent as I would like. Any questions?
Yeah, the 3 tools, and there's a couple of questions, Dr. Mins. The 3 tools, the travel restrictions would
How
be...
this virus first got here, by people bringing it into the country and then
Right.
spreading
So
from the
that's-
east and west coast to Kansas.
So travel restrictions would be difficult, as you
Those
said.
are difficult.
But screening, contact tracing, remaining 2 weeks in isolation, you've given a good affirmative compliment.
That's one of the most potent tools we have, is
So
getting
that-
people out of society, out of circulation as soon as we can identify them.
So that's the second one that we, as the commission and our Board of Health, can help continue to support in a large way.
Mm-hmm.
The third one is this behavioral characteristics, which we as the commission can encourage our companies and retail and everybody 6-foot increments, plexiglass, encourage the elderly and those that are at risk to stay at home as much as they can. And the third one there, and that part is what you just talked about with masks.
When we're out in society, circulating closely with people,
Correct.
I don't wear this mask in my office, I don't wear it in my car, I don't wear it at home. But if I'm going out to meet with a group of students, I put it on.
Right. Okay. That's really what you've explained there is very helpful. And you said at this point you're emphasizing a stay really cautious approach, just as what you said with the tools, and you're not recommending that we close businesses or things like that yet, or not yet.
I acknowledge the damage that we did to the economy with closing businesses. I think we're at a level now where we don't need to do that, but we can't let this level get
Right.
out of control.
So we can help support and elevate the behavioral characteristics category you're talking about. Okay, thank you.
And I will assure you, as soon as we have a vaccine that works and I get my dose, I'm going to burn all these I have. Not quite.
All right. Commissioner,
Thank you for your time.
Wait, Dr. Mins, Commissioner Howell has a question, please.
Yeah, thank you again for the information. I do have a couple of questions. Number one, on the N95 mask, I've noticed there's what appears to be a vent hole in that. I think that's an exit port. Can you confirm that?
Well, the purpose of the N95 is not so much to protect others around you, but to protect you from inhaling the droplets that are very microscopic. So that valve closes on inhalation, but then it opens up when you exhale to help the air get out so you don't feel so claustrophobic.
Right. Well, so we ought to differentiate between different kinds of masks because you said a minute ago that if you're wearing a mask, if you have the virus, you could protect others from getting it. But if you're wearing an N95 mask in that situation, it really wouldn't. Would that be a fair statement?
It depends on the kind you have. Most of the N95s we're using in the city don't have that valve on it. They're just a solid
Just a
mask.
filter membrane that goes across.
A solid mask.
I actually had a friend who related a story to me. He was actually wearing an N95 mask and sneezed, and
Yeah.
he was using his phone at the moment, and the part, his sneeze went basically onto the phone.
Yeah.
And he was surprised by it, and so
Yeah.
it opened my eyes.
That's not the kind of mask they should be
It just shows
wearing.
you that it doesn't stop the virus if you're using that type
Right.
of a mask.
That's
And
correct.
so it does help the person who's wearing the mask. So you have to understand, I think,
Right.
having that deeper understanding, I think, is very useful
Right.
for everyone. You mentioned a minute ago about hospital trends. You said there was 17, I believe what you said, 17 in the hospitals today?
That's what the report on Monday said.
Okay. Well, a couple of weeks ago, you came here and you said there was 11, and that was very useful, by the way. And I want to say I appreciate you sharing that information. I have been frustrated because as a member of the Board of Health here, I think the most objective number we have, we talk about slowing the spread of protecting our hospitals. We have to know our hospital admission rates. I'm going to ask you, Dr. Minn, would you please ensure that the county commissioners are able to access hospitalization and admission rates for COVID-19? I think we need to know that number. It's the most objective number we have. I mean, we're talking about 200 active cases or 250 active cases. That's not as useful because we don't know how many of them are asymptomatic, for example. What we do know is hospitalizations are critically important for us to understand. And I would love to continue to get that information if that's okay.
This is published every day, this report.
I do not get that, sir.
And it has a column here, currently hospitalized, recovered, home.
Can you make sure that we have a way to get access to this document each day, please?
Yes, I will.
I believe those numbers that Dr. Minn just gave you are on the dashboard every day, sir.
I have been looking at the dashboard every single day for a long time.
We'll double check that, sir.
They do have, okay. One other question I have is, Dr. Minn, out of all the things we've heard about how to mitigate the risk of transmission, we've talked about washing hands and social distancing and wearing masks. If I understand correctly, when you speak with someone and you're in close proximity to each other, that's when the masks become useful.
Most useful. Yes.
But doesn't the virus also go into the eyes, for example? Is that another way that someone can receive the virus?
Usually that's from people scratching their nose, then rubbing their eyes.
All right.
That's why we wash hands and things like that.
Okay. And then I guess I would like to say, if someone had the choice between social distancing, staying far from other people, and maybe not wearing a mask, or being next to someone else and wearing a mask, which is the more dangerous in your opinion?
You know, and I'm not trying to weasel out of answering you, but there's a lot of things, again, we haven't had time to test, and some of them are very hard to test. I don't know of any studies that have compared the two. So I think
guess my point is this. I see lots of people who think that because they wear a mask, the social distancing is not important. And I'm just going to make a point here that if they believe that, we're also essentially embracing, if you will, a false sense of security on that aspect. That's not probably true. I think the mask, as you said, it suppresses or it attenuates, if you will, to some degree. And I think that's based in theory. Obviously, I think that's true. But it doesn't stop the virus. And my point is, if someone really wants to be protected, ignoring social distancing and wearing a mask is frankly not the right strategy here. So if we want to encourage the best behaviors, it's all the things we've talked about. But maybe out of all the things we've talked about, the one that probably has the greatest impact is social distancing. That's my opinion. You're welcome to comment on that, but that's my comments and questions. Thank you.
I would include that in our toolbox of those behavioral issues, and I feel we need to take care of all of them because we need to keep this virus at bay as best we can. Everyone's important, but I agree the 6-foot distancing, very important.
Okay, Dr. Minn, Commissioner Cruz has a question.
Thank you, Chairman. I want you to address some misleading information around masks and carbon dioxide. Can you talk about that? Because I've had some folks who have shared some posts, have asked me questions about wearing a mask and breathing in the CO2. Can you talk about that?
Yeah, I haven't seen these posts, so I don't know exactly what they're claiming. The N95s they're tight. So, but when you breathe out, the air's got to go somewhere, so it goes around the mask. These masks are mainly a barrier. They're not stopping airflow very well. So I'm not sure. I don't understand what the claim is about CO2.
Just like they're breathing it in instead of exhaling it. It's because the mask is not allowing it to go away from them. So
these masks are pretty open on the side.
Okay.
I've never seen a patient who had carbon dioxide retention because of wearing a mask.
Thank you. I wanted the public to hear it from you.
Yeah.
Thank you for that. I appreciate it. Also, I think we have the hospitalizations up.
Right, and I kind of want, maybe give Kate a shot to talk about that. You want to talk about what you put up?
Okay. I'll get the 6 foot here.
The information that you just received on the handout from Dr. Minns, it's shared a little bit differently on the dashboard. And so you'll see the hospital admissions and releases. We also have, where is it? The information on demographics. So you'll see there's the information you have is just in tables, and we've got it in a different format here on the dashboard. So age ranges, genders, different demographics like that, it's on the dashboard, but it's just shared a different way.
The top number, 791, is the cumulative number of cases we've had in Sedgwick County to date. So that's my point. The prevalence is so low.
So let me just chime in here. So again, I understand everything I'm looking at there. The number I want is that number 17 at the bottom of the sheet, and that's not anywhere on the dashboard. I've been asking for this data for the last 2 months, and I've got it sporadically. I got it from you 2 weeks ago. I got it from you today, but I've been asking for this data for 2 months now, and I've been told repeatedly that hospitals will not share it, and I'm not going to be able to get that information. That it's confidential, and that basically I'm just going to be left in the dark. It's interesting to me that the news media has reported these numbers fairly easily, but for whatever reason, the Board of Health can't get the numbers. And so I appreciate this. I need to make sure I get that number as often as anybody else is getting that number.
Well, let me make one.
Doctor, could you get the microphone, please? Thank you.
So that report is Sedgwick County residents hospitalized. Our hospitals also have some cases from Ford County and other patients that were referred in here because their counties couldn't take care of them. So I'm going to make clear, they may have more cases than that report shows.
This is exactly the number I need. Appreciate you so much for clarifying.
I'll work on getting that to you.
Thank you.
Any other questions?
No, Dr. Minns, thank you. It's been very educational, very helpful, and thanks for the discussion.
All right,
And
thank you.
Thank you for spending your time.
Thank you.
Have a good rest of the day.
Appreciate it.
Lindsay?
Okay.